Everyone should now have permission to record the meeting. If you are not able to and you would like to, please send us an individual message in the chat box so that we can make sure that we have clicked the permissions correctly. So we are joined today by Snohomish County Executive Dave Summers, by Dr. Chris Spitters, the Health Officer for the Snohomish Health District, and by Dr. Matt Lacey, the Chief Medical Examiner for Snohomish County. So with that, I'm going to go ahead and hop off and hand it over to our guests.
Well, thank you, and thanks for joining us today. So since the beginning of the COVID-19 pandemic, one concern of ours and one possibility is there might be unmonitored pockets of the virus spreading in communities that are hard to reach, in particular those who are living without permanent shelter. Without interventions into those communities, they could see significant outbreaks and contribute to overwhelming our healthcare system and also spreading the virus more widely throughout our community. So we needed to innovate, and so I'm proud to announce today we are forming and have started a new pilot program that we are calling our SAFE teams. SAFE stands for Snohomish County Agencies for Engagement. These teams will be composed of physicians, community paramedics, social workers, and law enforcement officers. It's really an extension of our embedded social worker program that has been really successful over the last few years. So it's really a great example of a partnership and collaboration across multiple sectors, law enforcement, our medical folks, and our social teams. So the SAFE team will be visiting encampments in areas where people are known to congregate, and we will be assessing COVID-19 symptoms and connect people to services as needed. So these efforts are just part of the coordinated efforts that are being led by the Snohomish County Department of Emergency Management. It's just one aspect. The other activities will continue, but we thought this was a very important intervention into these communities and really an important community mitigation program. So we want to really thank our partners in this. And as we move forward, also, we are planning for recovery, particularly to help our business community that's been very hard hit. I have a task force of business folks and community leaders that will be having their first meeting on Monday to begin to come up with some plans and strategies on how we can all work together to help our businesses as we come out of this pandemic. And very happy and was very pleased to see that Boeing will be commencing operations at the Everett plant. Really, the first folks are showing up today, senior managers, et cetera, and the first shifts will be starting up on Monday. So I'm glad to see that. And I know they've put in significant safety features for the workers there at the plant, and grateful that they're able to start some operations there. So our residents have really been successful at flattening the curve. The virus is still out and around all of us in our community, so we need to keep these efforts up. And we need to keep this thing a lid on it so we don't overwhelm our medical system. So keep doing what you're doing. Thank you for that. It's working. And as we move forward, we're going to be looking for ways to progress safely for all our communities, all our family members and friends. So with that, I'll turn it over to Dr. Spitters of the Snohomish County Health District.
Thank you, Executive Summers, and good morning, everyone. Today, I'd like to share some reminders about stay home, stay healthy, to discuss COVID-19 compared to the flu and give you an update on some data. First, I'd like to build on what Executive Summers mentioned with the news of Boeing phasing back into operations. Boeing has been working to make significant adjustments to their operations with COVID-19 in mind and are doing so as a critical infrastructure and essential business. It's worth keeping in mind that non-essential business activity remains unapproved by the governor's declaration, But nonetheless, as we look forward down the line, all businesses in our counties should be anticipating what they would do when the time comes that they're allowed to return activity. And so if you haven't already done so, we really encourage you to start thinking about that. You can look for materials on the Snohomish Health District website, as well as the Department of Health and CDC websites that address businesses. So planning for how you will phase back into operations with respect to COVID-19 is important. And as Boeing is demonstrating, not everyone will be returning to work at the same date or same time. If telework is an option, obviously we encourage and promote that as much as possible to maintain social distancing as efforts to restart some semblance of normal activity returns. Evaluate options for staggering shifts to reduce the number of employees in an area at a given time, staggering lunches, breaks, etc. Ensure that employees will perform self-health checks before or as they arrive at work, and then reporting if they have symptoms, and then not entering the workplace at that time if they have fever, cough, difficulty breathing, or other symptoms of a respiratory infection. Likewise, if they become ill during the day, they should be sent home immediately. Understand that cloth face coverings will become a new normal for us for a while, especially in settings where physical separation of 6 feet or greater cannot be maintained for an extended period. Encourage employees to wash hands prior to leaving work and again upon arriving home. Changing and laundering clothes or showering after work are other good practices, especially kind of doing that in the entryway of the house or the garage, leaving those materials behind before entering the common living area where others share space. For the broader community, I want to remain clear, we are still under a stay home, stay healthy order from the governor. As some essential businesses restart or expand, they are there to perform just that, an essential business. Now is not the time to venture out for a play date, visit family that you haven't seen in a while, or engage in other activities that really aren't necessary. We must remain steadfast in our collective commitment to slow the spread of infection. And meanwhile, as over the coming period, we take or observe efforts to resume some normal activities, we will be closely monitoring data and coordinating with our other public health and healthcare partners to ensure that cases don't increase. But again, meanwhile, for the vast majority of us, there's no change in the governmental or public health direction about your day-to-day activities, which are to stay home unless you have an essential activity. Both I and my colleagues are noticing over this week a substantial increase in the amount of morning traffic. And I saw the morning lineup southbound, which I haven't seen in a couple of months, resuming. So just a heads up to try and avoid unnecessary trips, please. Some people are wondering why we are requiring and continue to advocate social distancing and putting in so many measures for COVID-19 when people die from other respiratory infections like the flu every year. And sometimes comparisons are made between COVID-19 and influenza in terms of the losses of life in our community. It is true that COVID-19 and the flu are respiratory infections. Both can be deadly. But first, COVID-19 is about 10 times as deadly, at least. We observe fatality rates of about 3 for every 100 cases reported. Maybe the real number is somewhere down around 1%, but that's at least 10 times greater than the average annual flu outbreak, which is 1 in 1,000 cases dying. And it's important to recognize that COVID is not the flu. The length of the flu season varies, but it lasts for months, every winter and fall, sometimes extending into spring. During the last 2 flu seasons, 40 to 45 people died. These were relatively high numbers, and even compared to recent flu seasons, but they're less than half of what we've seen this year so far, even with COVID-19. So we're really talking about completely different phenomena, both in terms of human suffering, hospitalizations, impact on the healthcare system, and loss of life. We also know a lot more about the flu. It's been around known to us for at least 100 years. We know the symptoms, we know how to treat it, we know how to prevent it. We do not have widespread immunity to COVID-19. We don't have a way to prevent it. There is no vaccine, and there is no proven treatment. So social distancing and containment efforts are really our only tool right now. The risk of transmission is also higher, and as I mentioned earlier, our losses of life and suffering are higher. So the measures we put in place are important to save lives and save healthcare resources. And it's worth remembering that 100 years ago, when the 1918-1919 influenza epidemic occurred and killed nearly 750,000 people in the U.S. out of the 100 million residents that lived here, those were transmission and death rates much more alike what we were anticipating without interventions here in the COVID-19 epidemic. And at that time, social distancing and a lot of the same measures that we're implementing now were in fact put into place. We had no vaccine to protect infection, and there were no antivirals for treatment. Again, 675,000 people died during that. 675,000 people in the United States died. 50 million people died worldwide from that. So to control efforts, we are using non-pharmaceutical interventions such as isolation, quarantine, good personal hygiene, use of disinfectants to clean frequently touched surfaces, and limitations of public gatherings. It worked then, it's working now, but we're not done. We've got to continue these efforts. These efforts may appear extreme, but they do work, and they work best when followed in harmony by the entire community. Now I'd like to turn to two things about data. First, I want to talk about some racial and ethnic data related to COVID-19. On Tuesday, we took a question about COVID-19, whether outcomes seemed different across race and ethnic groups, and I provided a partially reassuring report that our hospitalizations and deaths at the last look, which was about 2 weeks ago, didn't look any different. So I did ask our lead epidemiologist to take a look at the data that we have now, and based upon the roughly almost 2,000 cases for which we have race and ethnicity data, I do want to say that, like what we've seen reported in other metropolitan areas across the U.S., and that there is a racial and ethnic difference in the incidence of case reports. So Caucasians, U.S.-born Europeans have an incidence of about 85 reported cases per 100,000. Asians very close to that at 93. People of African American descent, though almost double, 157. Alaska Natives and Native Americans, 165. And Native Hawaiian or Pacific Islanders, 197. So compared to Caucasians and people of Asian ancestry, Latinos, African Americans, or others of non-foreign-born Africans and Native American or Pacific Islanders appear to have roughly double the rate of disease. And I would tend to just refer you to comments made at the national level about why that might be. One, in terms of risk of acquisition, to the sad and difficult extent that race and ethnicity are tied to occupation and income to a degree. Lower wage earners tend to have less flexibility around social distancing and doing remote work. So that might be greater risk of acquisition going to, coming home from, or being at work. And then some of the underlying conditions which predispose toward poor outcomes, like diabetes, high blood pressure, heart disease, lung disease, asthma, we know are more prevalent in these populations. Some of the inequities that exist in our society around health related to race and ethnicity. Hospitalizations are numbers are small, but it does appear, so we can't calculate reliable rates for African Americans or Native Americans just because the number of hospitalizations has been so small, less than 5. But even when you extrapolate those up, we don't see a difference, but again, small numbers, hard to draw firm conclusions. Latinos, we do have enough numbers, and it suggests that hospitalization rates may be 50 to 75% higher than for Caucasians and Asians. And then death rates in the minority groups, numbers are really too small, and so it's really hard to say anything definitive. But what we can see is that Asians, Caucasians, and Latinos don't appear to have any significant differences in death rates. So that's a little bit different than what's been reported in other settings. Again, the caveat, small numbers in African Americans and Native Americans. Second data item, I want to just talk about how we collect and record death information. The Snohomish Health District receives reports of deaths associated with COVID-19 from a number of sources. These include hospitals or healthcare facilities, other state or local health departments, the Snohomish County Medical Examiner's Office, and through our very own case investigations. All death data provided are confirmed either through test results on COVID-19 conducted before or after death. There could be other underlying health conditions that contributed to the death, but if COVID-19 was diagnosed in proximity to the death, it's still considered in public health terms a COVID-19 related death. So for instance, someone who has congestive heart failure, much like in this way, similar to influenza, develops a severe illness due to this viral respiratory infection, ends up hospitalized, and because their overall health status is marginal, so that COVID infection and its consequences can be enough to cause fatal disease, whereas in someone who didn't have congestive heart failure, it wouldn't. And so congestive heart failure was contributing, but so was COVID-19. And so those are counted as COVID-19 associated deaths. Our county level death data will likely not match numbers provided by the Washington State Department of Health or the Snohomish County Medical Examiner's Office because of the diverse sources through which we seek that information. So we'll tend to have higher numbers than you see from those other sites. We will provide numbers for Snohomish County residents with death associated with COVID-19. If a resident died in a hospital or facility in another county, they would still be counted as a Snohomish County death if they in fact resided in Snohomish County. And numbers sometimes vary between reporting agencies depending on the time of day and when the counting is done. So that wraps up my comments for this Friday. To share more about the processes that they are involved with and what they are seeing with respect to COVID-19, I want to turn it over to our Snohomish County Medical Examiner, Dr. Lacey, for his comments. Matt?
Thank you, Dr. Spitters. My name is Matt Lacey. Good morning, everybody. I'm the medical examiner here in Snohomish County. The medical examiner has the legal authority to investigate sudden and unexpected deaths. But one of the types of deaths that we investigate are those that are thought to be due to infectious disease that have a public health concern. And obviously, COVID-19 falls into that category. That being said, the majority of deaths in Snohomish County from COVID-19 are coming from people who are dying in hospitals. They have a diagnosis. They have a doctor who's aware of their diagnosis, who signs their death certificate. Although we are often made aware of those cases, we do not we, meaning the medical examiner's office, do not get involved because it's a natural death and it's clear why the person died. Where we do get involved are cases where persons die in the community, in their homes or in non-hospital type facilities with suspicious symptoms. And by that, I mean fever, some sort of new respiratory complaint, and no other adequate explanation for that. Those are the cases where my office gets involved, and we may perform post-mortem testing for COVID-19 to determine if those deaths are related to the disease. We do autopsies in limited types of cases, ones that there might be other reasons to do an autopsy, or ones where we think the person is unusual in terms of their characteristics for a COVID-19 victim, and we might want to do an autopsy to confirm the infection. But in the majority of cases, we are simply doing the nasopharyngeal swab testing that is the most common test now for the virus. And in those cases, we use a very rational approach. I've already kind of laid it out. It would be somebody who has a risk factor, such as an exposure, or they're coming from a facility where there's a high incidence of the infection. They have a fever in the last 2 weeks of life. They have new and unexplained respiratory complaints. And in those cases, we would do a test. If the test is positive, then typically their cause of death statement would list COVID-19 as a cause, with the other conditions they have as contributing factors on the death certificate. We are doing very few of these tests overall. I think approximately 30 times since COVID-19 started have we tested people in the community who may have had it, and roughly a third of those have been positive or are still pending. So we are finding cases, but not a great number of them. In terms of the death certification, again, we use a rational approach, in my opinion, and really nothing has changed about the way we certify deaths due to COVID-19 from any other type of infectious disease. And we certify infectious disease deaths every year. If it is rationally the underlying cause of death, it is so stated on the death certificate. If there's no rational reason why it would have contributed to death, the fact that somebody may be infected doesn't go on the death certificate unless it causes the death. So that's our approach here in the medical examiner's office. Again, we're certifying a very small number of the deaths in the county, and I think that's true in medical examiner's offices nationwide. Most of these deaths are certified by clinicians. But I'd be happy to talk about our process if there are any questions later. Thank you.
Perhaps Dr. Spitters has a question about we talked last week about the need for more testing before we can ease up. What specific plans do we have for more testing? You're still on mute.
Oh, sorry. Thanks. Thank you. So testing, having a widespread availability of testing is a key ingredient as we come down the other side of the curve here, and cases become fewer in number, and the value of detecting, isolating, and identifying the contacts of cases for quarantine becomes of greater marginal impact than it was at the top of the curve. And so the goal is to have rapid turnaround testing. The idea is for people who have symptoms within the same day or the next day to be able to seek testing, get results within a day or two, so that then they and we can notify their contacts to quarantine. That's the basic principle. The chief, we've had various bottlenecks along the way in testing. Initially, it was just development of a test, then making the technology widely available. Then the personal protective equipment was a logjam for a while. Currently, the main limitation on availability of testing is about availability of swabs and transport media for the collection and of the tests. So that item that moves from the patient's nose to the laboratory. That's not really in our control. We certainly have requests out for swab kits and viral transport media to get that into the community, just like we've been asking for masks and such. Ultimately, I think we'll get there. I do think it's worth noting that, each week in Snohomish County, we get about 2,500 tests done. And that may be adequate. We're in consultation with the state health department going forward about all the branches of the transition containment and mitigation efforts going forward. And so, identifying that number, what's appropriate for a population of 800,000 people with the amount of disease we've had. That's still under development, but we may not be far off, really. And it's more about, as time passes, I think, trying to move testing from remote testing that takes 3 to 5 days sometimes to get results back because it's going to a commercial laboratory somewhere, and trying to move the testing closer to the patient so that the turnaround time is lower. And that's a matter of, commerce and healthcare systems moving forward a process, again, that's only been underway for several months. So I remain optimistic about it. I think overall the amount of testing that's being done is a huge improvement on where it was at the end of January, and we've just got to keep working on that.
So, Doctor, this question about the drive-through test facility and its status and how much longer to be open.
Yeah, so I think our plans, the interim plan is that this was the last week of drive-through testing. You'll recall that the support for that was withdrawn by FEMA, and we are demobilizing that effort today. Demand kind of declined over the course of that. Plus, we don't have the funding and support from the federal partners for that. They did leave some swabs behind that we're using in long-term care facilities. So we're really moving our active testing from the health district to high priority, high incidence settings, like namely long-term care facilities where outbreaks are ongoing. So that's where the health district's testing capacity will be focused. And then we're in the process of acquiring a point of care machine to supplement that activity, and maybe get another one out there in a key primary care setting that might need to augment its testing capacity. But again, I think we're going to focus the health district, the public health disease control capacity for testing where there are fires burning, and then try to keep the overall testing system strong through the primary care and walk-in clinic sector. And we're still looking to see if, obviously if the future changes, either in terms of supplies or demand for that kind of testing, we'll try to stay nimble and be able to respond.
So there's a question about the SAFE team, and if it's an expansion of the embedded social worker team at the Sheriff's Office. Yes, it is an expansion. That embedded social worker program has always been a partnership between my Human Services Department and the Sheriff's Office, and we're adding in medical personnel. That's important so that they can talk to the folks, assess their condition and symptoms, make sure they're being handled properly and in a safe manner and connected with the services that they need. We have the Isolation Quarantine Center at Angel of the Winds Arena and other abilities. So it really is adding the medical capacity to those teams. There was a follow-up question about the COVID and classified deaths, and the example was given if somebody was hit by a car but they had COVID, would it be listed as a COVID death? Does somebody want to clear that up.
Sure,
Maybe why don't you take a crack at it, Matt, and then I'll follow.
Okay, yeah, I'll touch on that. There's nothing different about the certification of COVID-19 deaths specifically than any other type of infectious disease death. So the example about the person hit by a car, no, COVID would not go on the death certificate. And just to be clear, the medical examiner's office is not testing every death for COVID. We're using a rational approach and only testing people who we think may have it or may have died from it, but somebody who clearly dies of trauma, for example, we would not even test for it. So only the rational cause will go on the death certificate.
Right. Thank you. In our last call, experts seem to agree that widespread contact tracing is going to be key as the pandemic begins to wind down. Does the health district have funding or a plan for hiring additional workers to do this contact tracing?
So this is a state level initiative that's underway. We're working closely with the state health department which is leading an effort to basically lay out the technical plan, the human resource needs, the technology that would complement human resources, and then how that would all be implemented. So that's a plan and process that needs to be in place before there's any significant lightening up of social distancing. And beyond that, I can't comment more on it, not because there's any big secret, but we're still in the early stages of working through what is a substantial human resources, technical, and financial endeavor going forward.
Great. Thank you, Doctor. And I think that was our last question. I appreciate everybody being on today, and we'll be back on Tuesday. Thank you.